Welcome, everybody, to today's webinar with the Accountable Care Learning Collaborative. My name is Tom Merrill, and I will be moderating today's call on selecting high-value provider partners, keys and insights to selection. We're excited about today's presentation and the opportunity to hear from Dr. David Muhlestein, the Vice President of Research at Leavitt Partners, and Dr. Jordan Asher, Chief Clinical Officer and Chief Innovation Officer at MissionPoint Health Partners in Nashville, Tennessee. We are excited that you're on with us today. A few housekeeping items before we get started. To minimize feedback, please mute your line. If you're dialed in, please use your phone's mute feature. And if you're using your computer only, click the microphone icon. If you're using both a phone and a computer, it's best to select the telephone option under Audio in the GoToWebinar window, then mute your phone. There will be opportunities for questions at the end of both David and Jordan's presentation, so please, you can submit them along the way using the question box in the GoToWebinar window. And today we plan a few things, so let's go to the agenda. So we will quickly review some updates, some upcoming events for ACLC membership. I will then introduce our guest presenters, which, as you can see here, are Dr. Dave Muhlestein of Leavitt Partners and Dr. Jordan Asher of MissionPoint Health Partners. And then we'll have the Q&A. So real quickly, the next member meeting for ACLC membership will be on February 20th. And as many of you have already heard, this will be co-located with the HIMSS conference. Very exciting. A lot of our membership will be there anyway, and so just a great way to economize some of our travel. This is going to be a great conference, and I think on both fronts. Members of the ACLC, just as a reminder, are invited to attend a second healthcare conference day that will be Tuesday. So we will be there on Monday, and then the Tuesday following is a conference hosted by Leavitt Partners, as many know, a sister organization, and so you are invited to stay for that, and it will be great. Please look for the registration links in our weekly news that will come to your inbox every Tuesday morning. As far as work group calls are concerned, our next calls will be tomorrow, actually, December 15th. Tomorrow at 9 a.m. Eastern Time will be the first of two calls. CSB, which stands for Case Study Brief. We're going to do a Case Study Brief deep dive. Tomorrow 9 a.m. will be on UT Southwestern, and the topic will be Promoting Bottom-Up Innovation, which is a governance competency. So we're excited to sort of pilot out these meetings and see how it goes. The next one will be just after that at 10 a.m. Eastern Standard Time, and we'll feature a signature medical group on integrating social factors in maternity care, and that is a patient-centered competency, which I'm pretty excited about because I'm the work group manager for that group in particular. So you are free to join one or both of those, and we will love to hear your feedback from those calls. So moving ahead, let me introduce Dr. Muhlestein. David is the Vice President of Research and Development based here in Salt Lake City. He directs the study of accountable care organizations through the Leavitt Partners Center for Accountable Care Intelligence and leads the firm's quantitative evaluation of healthcare markets. He is an expert in using policy analysis, predictive modeling, and applied analytics to understand the evolving healthcare landscape, and we're excited to have David on with us today. We also have Dr. Jordan Asher, who is MissionPoint's Chief Clinical Officer and Chief Innovation Officer. As I mentioned, they are in Nashville, Tennessee, and so we're really glad to have him on today. His role concentrates on creating innovative models of care delivery, as well as providing national thought leadership directed towards the future of healthcare. Jordan is also responsible for the clinical oversight of the care models that serve as the foundation for MissionPoint. And Jordan's CV goes on forever, so that's how I summarized it. So we're just really lucky to have Dr. Asher on with us today. So at this point, I'm going to turn it over to David. So, David?
Thanks, Tom. So I'm going to summarize some research that we've been working on for the past few years as part of the Robert Wood Johnson funded project, where we've been trying to identify what are the characteristics of high-value providers and what does that mean for accountable care organizations and other risk-bearing entities as they start to create networks of care. And I'll highlight the website that's at the bottom of the page. We'll also include this with a summary email at the end of this, but all of the output can be found at that website, including issue briefs that summarize how to assess high-value providers. As an overview of the project or the presentation, I'm going to talk about generally what it means for partnering with accountable care, go through a decision-making framework, and then go through the specific provider criteria to assess high-value aspects of different ACOs. So the big question is, why do ACOs need to partner? I'm going to start with a slide that you've seen variations of before, and it's just showing the growth of ACOs. We know that it's continuing to increase the amount of activity, the number of organizations that are participating, and also the number of lives that are covered under these contracts. It represents about 10% of insured lives now. This is showing the growth, though, of the number of contracts as a relation to the ACOs. As you can see, there are more contracts than there are ACOs, and the growth of the contracts is faster. We're seeing two different trends that are happening. One is that organizations that started with pilot models, they were, for example, participating in the Medicare Shared Savings Program, have found success in that, and then have expanded into a Medicaid ACO or a commercial ACO. We're also seeing the increase in the size of these contracts, where somebody might have been engaged with a commercial payer with just the HMO lives, but as they've been able to manage them effectively and seen financial success, they've expanded into their PPO lives as well. So we're seeing an increase both in the number of contracts and in the size of contracts. This is talking to the prevalence and the growth of ACOs going forward. But as we look at the results from these organizations, we see that there's not necessarily any single model that depicts what's going to be successful. This is just using the Medicare Shared Savings Program. Results from 2015. And if you look on the right, this is the percent of organizations that qualified for shared savings as a function of the provider type. So you have hospital system-led, physician groups, or integrated systems. And you see that all of them are in relatively a close range, but also there's not a significant difference between the physician groups and the integrated systems. On the left, it shows the breakdown of the quintiles. So we took all of the ACOs and just put them into quintiles and looked at the number of beneficiaries, and then what was the average savings per beneficiary. And you actually see that smaller organizations tended to see more savings. Now, this doesn't mean that large organizations weren't successful, because there were certainly examples of large ACOs that had very strong savings and a very strong savings per beneficiary rate. But it's showing that there are opportunities for many different organization sizes to try to manage populations and do it effectively. The implication of this, though, is that as ACOs grapple with what care they should provide, they need to recognize what they can and cannot provide within the walls of their own organization. And smaller organizations, so for example, primary care practices that have a few dozen physicians that are starting to manage risk, they're not going to be able to provide all of that care that's necessary for that population across the continuum of services. So they need to identify opportunities to partner with different providers, different hospitals, different specialists, and other types of providers to effectively provide all of the need for those beneficiaries that they're serving. So the framework to approach partnering starts with defining what we're looking at. So the first step is looking at what value is, and value very succinctly is health outcomes achieved per dollar spent. And what we're looking at here is what is the output as a function of the input. So if you're putting money in, what are you getting out in terms of quality and financial performance for the organization? A high-value provider is an organization, it could be also an individual, but who delivers care in a way that delivers the best possible value, so the highest value in terms of price and cost. And a high-value system is an organization that facilitates the development of these providers. So it's bringing in the high-value providers and organizing them in such a way that maximizes their potential output. So what is the way that you can systematize the creation of value through your structure and your processes that you have in place? When you start thinking about deciding who you need to partner with, there's a three-step process that we've identified, and it starts with looking at the population needs. It's understanding who you're responsible for and what those challenges are that that population is facing. So from anecdotes from ACOs that we've spoken with and we've studied, there might be a strong need with a specific illness prevalence. So for example, in some organizations, they have a high rate of diabetes, and so they recognize that if they want to effectively manage the cost of their population, they need to address the diabetic population. They need to try to manage the diet, the medication adherence, all of the different aspects of tracking those needs. Other populations might say that their biggest challenge is on substance abuse. They found that people that are chronically misusing substances, they will lead to high related medical costs, and so they might have different opportunities than those that are really focusing on the diabetic population. So there's first a need to do an assessment of the needs of the population, and then tying with that is identifying what intervention opportunities there are. While you might have a specific need, you might not have the ability to intervene in it, or you might not have the way to do it that will eliminate the potential cost or quality impacts that are driven by the underlying case of that population. So identifying what interventions are possible and also what interventions are likely going to lead to the most potential benefit for that population. And finally, it's seeing what you can do inside your own walls and what can be brought from outside resources. And this is looking at the partnership opportunities. And so this is recognizing who the partners might be and what the capabilities that they bring to the table that will help with those interventions. So for example, if you are a practice that only has hospitals and just a few doctors that are working in those hospitals, you're going to need to identify social workers and other ways to intervene outside the walls of the facility and moving into the market. So when you think of the population, there's a few different ways that you can look at it, and the ones that we'll just mention are access, health IT, care management, additional staffing resources, and community resources. Access is looking at your touch points. How are you engaging with the population, and what are the different ways that you can do it? Can you do it through telemedicine? Can you connect with them through the pharmacies that they're regularly visiting? Is it through other means as well? Health information technology is how are you connecting both your population with the providers as well as amongst providers, and how are you identifying what your opportunities are on your technology side. Care management is trying to see how you manage the specific patients and who those managers are and what their responsibilities are and what their ability is to intervene with the care of those patients. Staffing is just looking at internally what you can manage and what you can make changes with, and then community resources is looking outside of the traditional care delivery process and seeing what chance there is for engagement with the patient population. At all of this, it's trying to create a customized strategy that recognizes the needs of the population and also what the capabilities are of the organization with its partners to provide those interventions that are going to lead to a significant impact. Now, as we think about impact, you've all seen variations of this figure on the left, and what this is looking at is saying what are the factors that affect the total health of a population. And as you can see, medical care and environment represent collectively about 15% of the total health of the population, but are a significant portion of the total care that's being delivered. As we think of the care delivery system, the vast majority is focusing on a very small point of the contribution to health. And so there are many opportunities to identify other types of providers and other types of entities and organizations that might not be medical organizations that directly affect the total cost of care and the total health care outcomes of the population. And so recognizing what the organization can do internally and also what existing resources are outside that they can start getting involved with. So for example, when you look at certain populations, it might be dietary needs, and Meals on Wheels is a community-based organization that's able to supply many of the needs that the hospital system couldn't provide directly. So identifying where those opportunities are and then starting to integrate them into the broader care plan and the broader strategy for managing a population is really important. As we think about the sync thing, what does it take to really create a successful ACO? We think of these in kind of two phases. Initially is taking the core providers that are providing what we think of as medical care, those that are being provided by physicians and hospitals, and the care that has been traditionally provided or reimbursed through insurance. And so these would be provided under Part A and Part B of Medicare and kind of the standard benefit design of most insurance products. The next phase is starting to look beyond the walls of the organization and where they've traditionally provided care and starting to look beyond other additional care providers. And I'm going to talk about three today: post-acute care, behavioral health, and pharmacy, and just give kind of a general overview of where they might be able to provide additional benefits to the ACOs. The last few minutes of my presentation, I'm going to talk about the characteristics that we're specifically looking at for these organizations. And the key is that no matter the type of provider, they should really focus on characteristics of high value. And there's 7 different areas that we've identified of high value that we think are very relevant. It's the culture, patient-centeredness, system and public accountability, team-based care, HIT systems, performance improvement systems, and generally financial readiness. And in our on that website that I mentioned, there's information on all of these that really breaks down what they include, what they entail, and how you can start to assess these for different provider types. So I'm just going to talk about those 3 providers that we mentioned. So the first is the post-acute care providers, and I'll just mention a few highlights from this brief that we've put together and some of our findings. The first is that post-acute care providers encompass a broad variety of different care entities. So it could be skilled nursing facilities, long-term care, inpatient or rehab, home health agencies. There are a variety of different types of providers, and recognizing the spectrum of organizations that touch the care of patients after they've left the hospital, after they've had an acute episode, is first necessary. And the second is really starting to understand what their opportunities are and their challenges are with cooperating with an ACO and working with an ACO. One of the things that I'll highlight is their ability to track and share patient data. We know that effectively communicating information and sharing that is necessary for organizations to successfully manage that population. Most of these post-acute care providers are not as far along the pathway in terms of technology as physicians and hospitals are right now. Many of them are still paper-based, and they don't necessarily have the ability to electronically share and track information. And to understand the quality outcomes and what's going on, you really need to identify providers that either have that capability or have the willingness to adopt that capability going forward. The next is behavioral health providers, and behavioral health providers are somewhat unique in that they have the ability to influence a small subset of patients that represent a disproportionate share of total costs as they're looking at the mental, social, and kind of the physical needs of this population. We know that those that are suffering from mental and behavioral health have a high cost associated with them, and that usually shows itself or manifests itself on the medical side, so through their hospitalizations, through their physician visits. But many of these costs could be obviated by addressing the core underlying problem further upstream. One thing to keep in mind of this is that there is a shortage of these providers across the country, and in many markets there's not going to be a wide variety of behavioral health providers that you can partner with. Instead, you'll see maybe 1 or 2 or 3 at the most providers that are operating within your market, and it's a necessity then to not just try to choose which one is the best, but recognize you'll likely work with all of them and try to help them become a better partner. So how can the ACO provide services and training and capabilities to those behavioral health providers that will really help them more effectively manage the population? So what can the ACO, the risk-bearing provider, do to enable and to really maximize the possibilities of the behavioral health providers? The last one I'll mention is pharmacy, and pharmacy represents both clinical pharmacy and retail pharmacy, and what's really important about this is to recognize that almost all patients are on some form of pharmaceutical regimen, and they have the ability to really dictate the outcomes of much of their care. We know that most of the chronic illnesses that lead to collectively the highest cost of care are treated through these pharmaceuticals. We also know that pharmacists are licensed and trained providers, and in many cases are not practicing at the maximum ability of their licensure or their training. And we know that pharmacists engage with patients more often than almost any other type of providers. In many cases, a patient will see their pharmacist 2 or 3 times for every time that they're going to see another physician or go to a physician or a hospital. And so it's recognizing how can you engage with your patients using these resources that exist in communities and really trying to maximize what they can offer. There's a separate strategy for the clinical side as well as the retail side, but in both cases effectively managing this population or managing this therapeutic area will provide great dividends and great outputs for the population at large. So to summarize first you need to understand your population. You need to understand who you're serving and what the opportunities are for intervening with that population and providing some sort of benefits. Then looking at the providers that are necessary to provide those interventions and identifying who those potential partners might be, and then starting to assess them and identify what you can do to get the highest quality providers on board with you, as well as helping the ACO itself become a higher value partner as we're going forward. And with that, I will turn it back to Tom.
Okay, thank you, David. And we'll just let me just add that we didn't cover hospitals, primary care providers, and specialists, but those briefs are listed on the website that you mentioned earlier. So please go check those out, and we hope that they'll be useful for you. So now we will turn it over to Dr. Jordan Asher, who I did introduce in the beginning, but did not speak actually to what he will be speaking to. So David obviously just gave an overview of some of the research, and Dr. Asher will be describing how some of these ideas have actually played out in real life within his organization. So the concept and the practice, and Dr. Asher, the time is now yours.
Thank you. Thank you so much, and welcome everyone this morning or afternoon, depending on where you are. And first of all, I'd like to thank David for doing such an excellent job in really going through what we have found to be pretty much 100% true. And so what I want to do is take the next few minutes and really go through effectively in the same order, but talk about it from real life scenarios. How do we take that research into practice? What did we do? What have we learned? So a little bit about who I am in the organization that I've been blessed to work for is that I'm Jordan Asher. I'm an internist by trade who effectively was asked by a large health system, St. Thomas Health, which is part of Ascension, to basically create a population health management company, or an ACO. So we began that endeavor in 2011 and then have continuously grown, which I'll talk to you more about. But right now we are presently the tip of spear for Ascension, the largest not-for-profit healthcare, as it relates to population health and population health management companies. And we're presently working in 5 different states, lots of different types of populations, lots of different levels of risk, managing close to, in January, 350,000 lives. So we very much are in the thick of it. And I really appreciate the work that has been done. And in fact, the way I got invited to this phone call is that I received these as an email and read through the tools and the issue briefs and sort of called up and said, hey, let me tell you how I'm really using this in real life and how I use this in real life. And so that's what I want to walk through. And the first question that I think that David posed was, why do ACOs need partnerships? And I think that's an important point, because when we started doing what we were doing, we very quickly had to decide what could we build on our own to deliver clinical care and physician alignment, because we build networks as well as clinical models, and we do contracts with whomever will do a contract with us, whether it be a payer, a private employer, or the government themselves. But really, why do we need partnerships is because we very quickly had to decide what we were going to build and what we were going to buy. And the second part of what you were going to buy or who you were going to partnership also creates situations that you have to think a lot about, and I'll get into around lessons learned as you create these partnerships. Because you have to think about how much risk you want to pass down to them. How do you share that risk and the rewards if you do? What are the financial relationships? Because at the end of the day, if you are getting money to manage a population, how you split those dollars up and how you buy or build what you do becomes incredibly important. And that's where the issue briefs are very important, because as you're evaluating who you want to work with, you've got to think about it from lots of different domains or dimensions, all the ones that were mentioned, and then how do you think about that in a balanced way? So as David talked a little bit about what ACOs are doing, he is exactly correct. So for us, we very much think about this as new store sales and same store sales. So how are we going into new markets, into new populations? So we're right now managing lives in the MSSP in track 1 and track 3 in different places. We have commercial contracts with payers. We have Medicare Advantage contracts. We have Medicaid contracts, and we have contracts taking full risk directly with self-insured employers. So we really think about our growth as not in one-dimensional. We also support BPCI. We also do lots of things, and as you think about what you do, you have to think about it within the context of the work being done out there and what is going on. When David talked about the results, we have seen mixed results as well, and the results are very dependent on different things in different markets and different populations. In the MSSP world, depending on your benchmark or where you are, we have been successful in all 3 years, and in other areas, I'm not sure we're going to be successful, but that doesn't stop us from doing it for lots of reasons and learnings for other populations. David talked about high-value partnerships and high-value networks. And I want to thank him for not mentioning the word narrow networks or exclusive networks. Because at the end of the day, it's not about the size of the network you create. It's about who you're really working with and how you create that value together, that high value. Remembering value is really an equation of 3 components. It has quality and service in the numerator and cost in the denominator. So you really have to think about how you're going to create value for those that you are serving and who you work with to do that. And that's why I really liked the issue briefs and the scorecard, because it helps you discern how to think about that and down to the level of the questions that you need to ask. Now, a little bit about the tools themselves is that I do think about them as how they even interrelate to each other. So you got the intra-relationship of the questions and the domains as you're working with a partner type, such as post-acute care, such as primary care, hospital, whatever that group is, pharmacy or behavioral health. But you also have to begin to think about that, how they work together and the different components of them. So that's how we have sort of focused approaching partnerships. Now, as we've thought about approaching our partnerships, I really thought about it in a couple of different spheres and levels. And what was very interesting is that when David talked about his phase 1 and phase 2, because we are Ascension and we obviously have hospitals and we have employees, we did not think about it purely on how to leverage the assets we had. We from a market approach. So in fact, we ended up going phase 2 before phase 1. We obviously built the network, but we spent a lot of time focusing on phase 2 up front, because that's in fact where we found where the value was going to be. Because when we did our market research and scanned the environment and looked at the needs of those we served, we figured out very quickly that it was the diseases of life that really were paramount, and then their effective clinical diseases sort of were secondary. So we very much took an approach of how do we create partnerships, how do we create models to really impact those diseases of life and all those things sort of in a phase 2, and then going back and really optimizing it within the phase 1. From a timing standpoint, we obviously did phase 1 first, because you have to have those in your network when you're building a high-value network. And so that's how we began to look at it. And when we began to think about those things of the build versus buy, as I mentioned before, we really began to think about it, what are those partnerships? And those partnerships need to be not only in the usual post-acute care, the hospital, the primary care, the pharmacy, all that were mentioned, but there are other ones that we really thought a lot about. We thought about how do you do that in the behavioral health realm. Interestingly enough, we found that very difficult, because behavioral health has not consolidated itself in a manner to be a partner in a large-scale way. So we, in fact, found as we began to work with our partnerships, one of the things we had to do was help them figure out how to scale and grow to help us. And that's a very important point that I do want to make, and lessons learned, that as you become a partner and you look for a partner, you have to remember that the definition of partnership is how do I have you help me to succeed, but also how do I help you to succeed in your line of work as well. And that to me is a true partnership. So we went into all of these thinking very much, how do I truly be a partner, help you help me as I help me help you. And I know that sounds a bit odd, but I think that really helped us create some success. The other areas that we really focused on early is how do you arrange your contracts, because that becomes very important. The issues are the items that we really focused on was do we in fact put everyone wants to go at risk. Everyone's trying to get up the risk dollar. But what we found very quickly is that if you're doing partnerships with multiple entities, you can't put everyone at getting a piece of the risk dollar, because you start diluting yourself very quickly. And secondly, you begin to very quickly realize you have no way to know who caused what. And you don't want to get into that scenario, because at the end of the day, we have to be thinking about high tide raising all ships, or different ways of looking at that. And we found it very difficult to figure out, company A versus company B, how did you impact my risk? And we just were not able to do that. So we went much more into a model of how do I contract with you in a preferred way where you get what you need out of it and I get what I need, and the risk is whether that works or not, and does that relationship continue, versus saying how do I share in the dollar risk. That then stimulated a lot of need for feedback loops. How do we continually talk to each other? How do we hold each other accountable for the different parts? How do we work together on scaling? And then how do we work together on innovations where it really helps both of us as we move forward? Some of the lessons that we learned very early is that as we are doing this, you need an owner of that work, meaning you can't just do it, put the contracts out there, and not look at the measurements, because you will be very interesting to see what you find when you do begin to look at that. You can't set it up saying, okay, I've got these partnerships and I completely let go of what they are doing, because you will find that, in fact, the companies change over time. Their focus changes. How they're working changes. And if you don't keep an eye on it, then you lose the ability to really enhance, innovate, and grow. And so the ideal partner is one where you have someone that is also owning that relationship. So we have become very focused on how do we create a division that manages these networks, whether they're internal or external. How do we think about the innovation of what do we build internally versus what do we export and have other people work on. The areas that we found very early and started doing our contracts with very soon was, in fact, in the area of obviously post-acute. Both we have to remember our SNFs as well as our home health agencies. Now, what's very interesting, even in the MSSP world, with the waivers, we were able to go into these types of relationships as a bit of preferred vendor type relationships. And we were able to do that, and those have worked out very well. Concerning behavioral health, which was another area, we found that, in fact, we had to build a lot of that internally ourselves because we couldn't find partners that were able to sort of give us the whole piece. We have partnered and created contractual relationships for certain areas of behavioral health, but overall that, in fact, was an area that we could, that even though, for instance, the issue brief talks about what you need and how to go about trying to find and partner, we did not find it. So we said, okay, let's use these same learnings and let's see what we can create internally, because we found that the best way to go. And then as it became, as David talked about, really sort of figuring out the needs of your population, we have over 200 what we call health partners that do a lot of this work as it relates to working directly with the patients, the members, and the physicians. And what we found is there were certain things, even in the illness or disease realm, where we found that we wanted to work with partners that were very specific for very high-end situations. We did that around high-end COPD care, which was really sort of the only area, but we also think about it from that realm. What are those areas that even though I take care of the majority, when there is a minority that is out of my comfort range, how do I begin to think about that? I'm doing that with severe multiple skeletal issues, such as multiple sclerosis. So I've really, taken the work that came out of the research and the issue briefs and really do think about it and use it, and how do I use that to help frame my mind? How do I take that and say, okay, how do I make it fit my situation? I've even taken their work and put, numbers to it to create a balanced scorecard and how we go in and interview possible partners. So I really just wanted to take, 10, 15 minutes and talk about how we have put this type of work into action, how it does play out, and the importance of it. If I had to say there's one key learning as an ACO coming out of a large healthcare environment or an integrated care system, is you do have to think like a brand new company. You cannot think like a department or a division of some other entity. That just does not work. And if I had to say of what one thing has made us successful, especially in our partnerships, is realizing that we have to think completely differently. We have to think more like the demand side. And what I mean by that is that we have to figure out what is needed, and David really spoke to this in a different way, what is needed on the demand side, what is needed out there, what is value in healthcare, what is a high-value provider from the perspective of the demand side, and how do you set up your systems? Because in healthcare, we run the risk of really trying to solve all the problems from the supply side, meaning this is what I do, I'm the hammer, I need to find a nail, versus saying, what is the issue I'm trying to solve, and then what tool do I need to become to be? And therefore, I have to create a toolbox, and in that toolbox are the shapes that I have to take on, but also the other partnerships that work as other tools in that tool case. So I'm going to go ahead and stop here because I really wanted to leave at least 20 minutes for questions or to stimulate conversation. And so I am now going to turn it back over to open it up for questions or for conversation.
Okay, thank you so much, Jordan. We at the ACLC feel very fortunate that these materials made their way to such a thoughtful leader at a leading organization such as yourself, and these materials are being improved by people like Dr. Asher giving us feedback. So we want to open it up for questions, and so please use that little module in the bottom right hand to submit your questions, and so we will wait for those. But in the meantime, I'm going to take moderator's prerogative, and I'm going to ask a couple of my own. So, Jordan, I want to start with you, actually. You made an interesting comment that I think relates very clearly to the work that we do here at the ACLC, and that is that the ACLC and the members of this organization really think about our work here as being beyond just accountable care, that in some ways accountable care encompasses a lot of these principles, but that it is sort of, it's part of the essence. But you mentioned BPCI, that Ascension and MissionPoint are doing things in that realm. Do you feel like the concepts that David presented that you're working with have relevance to things like the BPCI? And for those who are not familiar with BPCI, that's the Bundle Payments for Care Improvement program that's run out of CMS. So, I'll give that question to you, Jordan, and David, if you have any thoughts as to that as well.
Sure, and yes, I do believe it's relevant. And first I want to start out by why we need to think about it. Is at the end of the day, the biggest payer of care is going lots of different directions, and to a certain extent, throwing spaghetti on the wall and seeing what sticks. We're also in a new administrative area that definitely has thoughts on the best way to get to value-based care. I'm not going to get political today. So we very much think about a market approach. And so when you think about a market approach, you have to think about what you are doing within the settings of the models that are basically the market. So whether if it's EPMs or BPCI, or EPMs being episodic payment models, or BPCI, which was effectively the volunteer version of that, you have to think about what do I create would also work in those other areas. Because at the end of the day, to be real honest, global or value-based care or global risk is nothing but a bunch of, bundling the bundles together if you think about it from a work standpoint. So therefore, I'll just use an example. How are we using our SNF relationship and contractual situation in our post-acute care side for our ACO work? How are we also using that same exact model and same work for BPCI work around HIPs, right? And how do I, as a company, deliver value for that as well? So we get asked to, or hired, or whatever you want to say, to help with those models as well. Also, as you begin to build your clinical models and your network models, you begin to see huge overlap in those areas because the needs of the patients don't go away. And then the last that I want to mention is at the end of the day, if you are accountable and you have someone else that is accountable for an episode, you have to figure out how to make sure to work with that episode, because let's just say it's a 90-day episode. That episode does not care about day 91. You do. So you have to think about how does day 89 look different than day 91? How do you use your partnerships and relationship to these different models and together? Because we are how we're incentivized. So using the same logic, using these same types of tools to think about your partnerships and your work, for us has worked regardless of the payment model because we have focused on it from that perspective.
I think that's a great response, and I'll echo everything that you said and just briefly mention one other point, and that is that with bundles, you already have your patient population identified. You have a very targeted population, and so you're able to drill right down on the very specific use case of where you need those partnerships and where your capabilities are. So I actually think bundles are kind of an easier foray into creating these partnerships because you don't have to grapple with the entire first phase of really assessing your population needs because they're much more readily at hand.
Well,
great thought. Go ahead, Jordan. Excuse me.
I completely agree. It also makes the contracting a little bit easier because you sort of, in a bundle, you sort of know it's easier to get at the volume of what's going to be there, which from the partners, that's always the first question they ask is, Jordan, what do you think our volume's going to be?
Great thoughts from both of you. David, let me ask you a question. Jordan brought up the help me help you. I was thinking of this famous scene in Jerry Maguire, help me help you. We talked during the development of this research about that this was mostly directed towards people who are looking for partnerships, but we also talked about the possibility that these could be used by partnership targets as a way to sort of prepare themselves. Is there anything you want to add there?
Yeah, I think the self-reflection is a really important part of this. It's not just looking what other people can do and what they bring to the table, but what do you bring to the table? And Jordan mentioned this, where it's helping them achieve their goals, their objectives, and seeing how you form this team. I know it sounds a little bit like rainbows and unicorns, but really getting people to work together and be a part of the same team across organizations and across ownership structures is a challenge, but it really is kind of that objective. It's the recognition that there's never going to be any single entity that can provide everything that a population needs. Because once you've figured out the hospital side, well, there's the post-acute, there's the pre-acute, there's the preventive care, plus all of the community-based factors and education factors, and just the further you go, you realize how everything is intermixed. There will never be a single entity, and so it's how do you work together, recognizing that you will have different organizational objectives. But I think you start by looking at yourself and you say, what does it really take for me as an organization, wherever I fit within this spectrum of care, to be the best partner that I can be? And so I think it's a very applicable use of the tool.
Okay, great. Jordan, a question for you. You brought up some phasing, and so here's a question. In the ACLC currently, we're working with competency, so there's a lot of very similar elements to the work that was done with this Robert Wood Johnson project. We are talking about competencies broken up by a domain, and our membership quickly pushed us to look at this idea of sequencing or phasing, as you brought up. How did your organization, or how did you, as you sort of look at this, how did you even start that process? What were some of the elements or criteria that went into that initial thinking?
Yes, so obviously you can't boil the ocean, and you have to think about it in versions, phasing, steps, however you want to think about it. And so, to David's point earlier, the way we looked at it is we basically did our market research and then decided directionally where we wanted to go, and then, started creating our phasing approach into that. So, for example, we knew that the market needed someone to focus on the non-clinical aspects of care. So we knew that we had to get physicians and hospitals in the network. So obviously, sequentially, those were important, but simultaneously and very quickly, we moved to those other domains that we felt were just as important. And so we sort of did it as an offset or in parallel, and then we knew there were other things we had to get to that we had to wait for the end. And I'll just give you an example off of the work. So, looking at the 5 issue briefs, you can even think about which of those, where do I sequence them? So, for instance, on the pharmacy one, I sequenced that later for me, and then even sequenced it differently within pharmacy. So didn't get to the retail pharmacy piece until 3 years into our work. Just now beginning to work with pharmaceutical companies in a different way. And you do have to, and I'm not sure I am stuck as much on a sequence or a versioning as the fact that you have to do it. So I'm not sure anyone could say exactly what step 1, what step 2, what step 3, but you have to create your steps and be adaptable to changing. Because the other thing that happens is that if you don't do that, you end up chasing shiny objects because you get distracted and you get scope creep and you forget what use case you're trying to solve, and you get driven by the external market, whether it be vendors or ideas or whatever it is. So you have to sort of create your purpose. You have to, create your versioning or your sequencing or your phasing towards that purpose. You have to be adaptable and changeable, and you have to think of things as moving in sort of off-step parallels versus pure sequencing, meaning I do 1, finish that, move to 2. I wish we had that luxury, but you really don't. Did that answer your question?
Yeah, no, that's great. David, did you have a comment? Okay, so I have a sort of related question. You brought up the this idea of partnerships making the risk-sharing process more complicated because it's hard to know who contributed what. And so you mentioned that just the relationship ends up being the risk element, that if the work is done well, then the relationship will survive, and if it's not, it won't. Did your organization make use of care compacts or anything like that? What are some of the, some of the detailed pieces that might go into such a strategy?
So you caught on very quickly what I said, because that is not a usual way of thinking about it. So very early on, I moved to, okay, I need to get into a financial relationship with you that being the partner that allows you to survive, that works for both of us. And figuring out the risk is not. So then you say, okay, then what are the service level details? And that's where we went. It's like, okay, our compact was the care compact, where service level definitions in the contract, as well as quality definitions in the contract that would be checked and looked at periodically. So that's how we dealt with the care compact or contract differently, regardless of the relationship, whether it was a compact or a contract. We then internally had to do our own research and our own looking to decide if there was value into the relationship that we created. Now, obviously, we worked with our partner on that data and things, but we held the responsibility of looking at that. Now, I know there are situations sometimes, to David's point, if you're a small group, you don't have that internal ability to do that. So sometimes you would have to rely on your partner to bring you some of that information. But that's how we created that care contract or compact. In fact, we did it mostly in contractual language within the contract, and paid the appropriate price for the care. We are not sharing risk, upside or downside, on those situations. And what was very interesting is when we really worked through that with our partners, they really liked that model better as well.
Okay, well, thank you for those operational details. Those kind of help us see where the rubber hits the road. We have no questions in the queue at this point, so we are going to wrap things up by saying, David, Jordan, thank you for your time. We appreciated your insight and perspective, and really thankful that you were able to join us. An audio recording of this conference will be made available and will be included in our weekly news summary. The next webinar will be Wednesday, January 11th, and the topic is, or the title is, Living in a Macro World. The topic is, how will providers be affected by this legislation? And so with the there are a lot of questions concerning the political environment that we now find ourselves in post-election, and so I'm hoping to address a lot of the questions that have been coming to us from our membership recently. We will have Clay Alsbach, who is very much a DC insider and someone who can speak to these topics, so we're very excited for that. If you have any questions about the ACLC or any follow-up questions from this webinar, please email members@accountablecarelc.org, and we'll be happy to address your questions. So thank you for joining us today. We hope you found this presentation to be worthwhile. See you guys.
Thank you.